If any clinician watches this episode, they need to understand that you feel like a different animal when you go to work and you become a healer, as opposed to a person who's only increasing the medicine dosages.
Dr. Hampton, it's a pleasure and an honor to be with you today and talk about liver disease and how you see things and treat your patients in your clinic. As a primary care provider, what can you just tell me a little bit about your practice? And are you guys solely PCP or are you multi-specialty group?
Yeah, well, I'm in a large health system called Advocate Health. Probably got about somewhere about 45 or so multi-specialty folk that come through. Maybe about 13 of us are primary care. I'm a family doctor with some training in obesity, master's in nutrition and functional medicine. So
When it comes to liver, because that's what our main discussion is over liver today, what are some of the common causes of fatty liver that you see in your practice?
yeah, I think there was a time when, alcoholic fatty liver disease, even in my training, I'm 54. And I remember when I started my training, it was definitely, alcohol as the primary cause, right? And in the 80s or so, we started noticing that the obesity epidemic became a bigger and bigger issue. And there's a large percentage of Americans now who have non-alcoholic fatty liver disease. So, and what we do in healthcare, and going back to this model of disease maintenance versus reversal, what we do is we tend to focus on, well, what's the best drug to keep that from happening, right? And what I'm saying to patients is, let's remove the poison. So if you don't consume the foods that lead to fatty liver, then you're going to be okay. And not only that, those tend to be the foods that turn into sugar. What kind of surprises patients is that, literally a cup of rice, brown or white, it's 45 carbs divided by 4, it's approximately 11 teaspoons of sugar. But who knew? Right. Tufts recently did a study where it showed that 6.8% of Americans are cardiometabolically healthy. That means that 93+% are not. And those are the people, which is the majority of the population, who can't tolerate 11 teaspoons of sugar at one time. So the goal is to help people understand what foods turn into glucose. I mean, that the glucose and the fructose can then turn into fat. And in the right person who's maybe more active, who may be younger, who can tolerate that, it's okay. But for many people, particularly in America, they struggle with tolerating that much glucose at one time. And by the way, too much glucose means you got to make insulin. Oh, by the way, insulin is a fat storage hormone. So if you have hyperinsulinemia, you're going to find yourself in a situation where you're more prone to the medical conditions that we consider chronic. I would argue they're not chronic. Most of these chronic medical conditions like type 2 diabetes are reversible if you remove the poison. And that's why I spend a lot of my energy with my patients, not talking about just taking metformin or Ozempic. I say, we can do those things as bridge therapy. And then you may find yourself not needing as much medicine or none at all if you don't consume the things that turn into, the glucose and the fructose. So with that perspective, they do really well.
So what I'm hearing you say is, from a therapeutic standpoint, you may initially start them off with something like Ozempic, which we're having shortages all across the world.
We are.
But you'll try and wean them off of that by changing their habits.
That's right.
Correct?
That's correct. And they won't really need Ozempic. And again, let's be clear. This technology that led to Ozempic is great, because what I found is that what we were tightly controlling diabetics with the advanced Accord VA trials, and we found that we tightly controlled them, and then all of a sudden they actually developed cardiovascular disease in spite of that, right? And so as I look back, they did do better with microvascular disease in terms of preventing amputations and kidney disease and blindness, but they had heart attack and stroke. But to me, it was obvious you're tightly controlling, not with lifestyle, but with insulin. And you get better A1C values, but what they miss is that it's hyperinsulinemia, which then causes all these other negative downstream effects, inflammation and things like that. So the key is not to tightly control with the medicine, but to then take this other approach. But the Ozempic is great, and the metformin is that they don't cause hyperinsulinemia. So those drugs, from that perspective, and that's why whether it's Jardiance, Ozempic, Trulicity, those drugs are great because they don't cause hyperinsulinemia. But the problem is, because of cost and other barriers, for those who need it, it's still hard for them to get it. But the most important thing is cheaper to just focus on lifestyle. And that way we can maybe help a larger group of people. Let's change the paradigm from we eat the right foods, then we need less medicine and we move off of the medicine, from take your medicine and make sure you're eating so you don't have a low sugar. So you have to, and that's how we've been trained. So, but to change that paradigm, we have to just ask our clinicians just to pause for a moment and just use a little common sense. If I don't eat the foods that raise my blood sugar, then maybe I don't need as much medicine. But they're not trained that way. We're trained to tightly control long-term, and that's what we're trying to move away from. And then if we do that, not only are we going to solve the issue around fatty liver, but guess what? We may not have as many heart attacks. We may not have as many strokes. We may not have dementia, which is now being framed type 3 diabetes, because they think dementia is a metabolic disease. So this whole metabolic world that we now are starting to understand that exists, that maybe we didn't talk about 10, 15 years ago, is a way to get return on investment, because now you're putting your energy into a lifestyle that'll fix a lot of the so-called chronic conditions that people have. Even today, as we record our session, I had 2 people who got off medicine today. Now, I've been practicing for 29 years. The first 19 years before I started doing this, I may have taken 2 people off medicines in 19 years. I took 2 people off medicine today. And one lost 44 pounds over the last year, was on 2 medicines, and she ran out of medicines a week ago. For some reason, it didn't panic her. And she didn't have to be panicked, because when she came in, her blood pressure was 130/70 without the medicine. So now we're saying, let's take one away. Let's hold on to the one, and let's see and don't take it any. Let's see what happens over it. If that continues, you don't need to take. So she got potentially 2 medicines. And then the other person was on, I think, metformin, and their A1C went from like 9 to 5 in the last 6 months. And they are also being told they don't need to take metformin. Now, she paused a little bit because people think they need their medicine. And I was like, no, it's okay. Your A1C is 5.5. So we can do this. So, and it all was lifestyle. So it was really remarkable. And so you feel, if any clinician watches this episode, they need to understand that you feel like a different animal when you go to work and you become a healer, as opposed to a person who's only increasing the medicine dosages.